कुछ interruption हुआ है क्या?
No, Jyoti, you are very much audible.
Okay.
हाँ.
So now we are not. Now we are at least accepting that we have to talk of contraception even during antenatal visits. That is why on the Government of India MCP card we have a block for family planning history and for what they are planning after postpartum contraception, and that is why in the RCH portal we have a column of postpartum contraception, and that is why we are having a stamp also. Even when the MCP card was not there, on our antenatal cards we used to have a stamp asking what they would like to have after delivery, because this is very important. You can't counsel during labor, and you can't expect the person who is giving care during institutional delivery to start counseling ABC and tell about the whole basket. So, and even the NICE guidelines way back said that counseling should start during antenatal period, and it should be discussed and decided and provision latest by 6 weeks. And so one can even catch up at immunization visit. So this is how when the renewed thrust of Government of India came on family planning program, we started saying that it is not only a question of population stabilization, it is of saving mothers and children's lives, and it is about sustained development. Then the focus in 2010 came on postpartum contraception, which was long awaited. So they did realize that there was high unmet need, and they started global commitments. After 2020, again, postpartum contraception had a major thing in it, and the 2010 trainings on PPIUCD did its job. Really, that is the most successful strategy of Government of India, the PPIUCD strategy. So, as far as this basically I've already covered. Now, the question comes: who should counsel? When the Government of India said PPIUCD, they actually gave PPIUCD counselors to many states. And many of my state people, Dr. Anita is also here, they started saying, okay, if you want us to promote PPIUCD, give us a counselor to sit in antenatal OPD and to sit in labor room. But, and as such also, family planning, when we talk about it, everybody expects either it is gynecologist's baby or it is, maybe the female medical officer's duty, or maybe maximum A&M. But gradually we have started realizing that it is everybody's job. Everybody heard Honorable Prime Minister on Independence Day also, he said family planning is everybody's responsibility. So even the couples, starting from couples to anybody who comes in contact with them and has the opportunity of counseling them, of exploring their unmet needs, should come up. So similarly for PPIUCD also, we have umpteen opportunities, and even I again say right now, since points of contact are decreasing, we still have opportunities. We have people sitting in their clinics working, so we can look towards postnatal ward. We can look toward where we can catch up. Babies are coming for immunization now, so immunization clinic is one opportunity. We have ICTC, PPTCT counselors. They are anyway doing HIV testing. They have a point of contact. Then you have the well baby clinics where you have a point of contact, and even a dietitian or a nutritionist who is dealing with couples with malnourished children also has an opportunity. Actually, I'm glad to inform you that in Delhi, I have tapped each of these opportunities over the last few years, and I have batches of these people, even dietitians. I have trained them in family planning counseling, even Ayush medical officers. So I'm trying to converge with so many people and skill build them on counseling. We can't just tell everybody to start doing family planning counseling. So we give them some basic resource material and some basic one-day training, and they start doing. So that is one thing. And now since I have taken over as principal training center also, I will be taking this more forward. We have trained several batches of male nursing officers also, and they are doing a good job for NSV counseling. So that is just besides the point. This thing, but for PPIUCD, all these people, because all the pregnant women are going to ICTC for HIV testing, they are going for nutrition counseling. So these dietitians and these people really come handy in talking to women about this. And when they hear so many mouths talk about this, then they will realize that it is really important. And of course, not to forget ASHA. They have maximum points of contact. They are accompanying with each antenatal visit. visit, they are going home, so they are there. So this is how role of Asha comes. She also talks to the relatives, because sometimes we have grievances, the woman went inside the labor room for a baby via PPI. Already pre-sensitized, then they are also in the loop, and they have maximum availability. If she has a query, then she will ask Asha rather than going to probably a nearby any RMP or any other practitioner who does not, who has not been in the loop earlier, may just remove the PPIUCD on first request of the woman. So that is also so ongoing support. And Asha also has supplies of, if she's on Chaya, she can give. Even during lockdown period, our Ashas have gone home and given the women supplies. While they went for senior citizens medicines, they also gave supplies of this. So timing of counseling, no doubt, it is the antenatal and early labor, and we have been. I already talked about this SAMP and this dedicated area for family planning on NCT card. So the choices, the whole basket is available. Only accepting the combined oral contraceptives, which is not available for first 6 months. Rest everything can be given almost immediately, at least before the first ovulation. So we should not feel at loss. And the timing of starting this chart is very well known to everybody. And when the different methods can be started, this is a very beautiful.
Jyoti ma'am, you can keep the microphone close to your mouth. You can catch it in your hand, because people are not. Yeah, that is better. You just keep it near your,
Okay. Maybe now.
Yeah, it's better now.
So I'm not going into the details of this illustration. This is very, very self-explanatory. Just want to highlight that centroman and progesterone only pills can be given in the labor room itself, postnatal ward itself. And of course, PPIUCD, we know that the woman comes out of the labor room with the baby and the PPIUCD. And as far as the efficacy is concerned, most of these things are highly efficacious, and together with the LAM support, chances of pregnancy really fall if there is good counseling, good method provision. Little bit about relevance in COVID era. I said interval services have suffered a lot, and even male participation has gone down because there are so many concerns. People are overwhelmed by other problems, and even the CAC services went down because people thought 3 weeks lockdown, maybe we can do NPT later on. And now also reaching out to CAC services, and many of our CAC service points are purely COVID hospitals, so that also has become a bottleneck in seeking services. So these are some of the slogans. We keep explaining the concept, and we keep through these slogans we know that the concept has gone down. Our service providers, क्यों ना बच्चे के साथ में IUCD की भी सौगात, अस्पताल दोबारा आना हो ना हो इसके बाद. This is actually from my mouth only. And these two are both mine. टीकाकरण और गर्भनिरोधक पर दो ध्यान, नहीं तो आपदा में नई आपदा से होंगे परेशान. This is a concept that we have to remember, and that is why the postpartum contraception really becomes important. So first of all, maybe I should start with PPIUCD because this is the most definitive and in today's date most feasible. We are not doing PPS in many setups because anesthetists are also reluctant, and there are SOPs regarding not doing elective procedures. So I will talk of this very important thing. So there are so many advantages of PPIUCD. We have not heard of any perforation with PPIUCD. The bleeding and all, there's no extra visit, there's no extra bleeding. It's all merged with the postpartum bleeding. And for the provider, there are so many. Although my providers tell us, Madam, we are so busy, so there's no time for PPIUCD. Our labor rooms are so busy. But I keep telling them that this is actually a time and energy saver. It is not taking your extra time; it is saving your time. Your counseling part has been done. Everything is ready. You just have to take 2 more minutes and finish this job, and you are really saving her life. So gradually we have convinced our providers that there are more advantages to it than any challenges. So this is very important to understand from both perspectives. The woman should understand how beneficial it is, and the service providers also. So timing, we all know, either it is post-placental within 10 minutes, or it is between 10 minutes and 48 hours. Beyond 48 hours, the category of MEC changes. So our intracesarean is the simplest thing. So the other thing is, later on, if we are not doing up to 48 hours, we defer it to 4 or 6 weeks. So this is regarding the timing. Most of the post-placental postpartum are category 1 if it is copper IUD. If it is LNG IUD, still it is category 2. And category 3 is only occasional conditions like chorioamnionitis during labor, prolonged rupture beyond 18 hours, and between 48 to 6 weeks postpartum is category 3. Category 4 is, of course, corporal sepsis, unresolved postpartum hemorrhage, endometritis, and extensive trauma that has not been repaired immediately. So we don't require much logistic. This is all one good Kelly's forceps with the recommended length and curve and no lock is what we require. And people also insert with hand, but we recommend a good forceps. And both the IUCDs are already available in all facilities. It should be available in the labor room and cesarean OTs also. How to insert? I want to know whether participants want to see a video or just I enumerate the steps quickly.
I think a video along with the simultaneous enumeration would be a better bet.
Okay, so yeah. This I'm particularly showing because I know we have lots of audience from the private sector, where unfortunately, 20% of deliveries in Delhi are in private sector, and we are really proud of our sector for taking our this much load because our public hospitals are so oversaturated. But somehow the contribution to the PPIUCD is not there. So I really want that take-up of this PPIUCD in private sector should be our next step. And with Dr. Mala Srivastava converging so well to me and so flexible and so, I mean, I just have to say it and it happens. So I think we can take her help because she's heading the AOTP now. And in the next 1 year, I really hope to see through this. PPIUCD see the light of the day in private sector. I'm sure मैम का ऑडियो बंद होगा नहीं तो मैडम कुछ बोल देती मेरी reassurance के लिए. Am I audible?
Dr. Mala, हाँ, you are audible.
Okay. नहीं मुझे लगा कि शायद वीडियो को मैं ऑन करने की कोशिश कर रही हूँ.
It's okay, Dr. Jyoti. If
last में कर दें.
Technical difficulty, we can go ahead with the step-by-step approach.
वो वापस शेयर कर दें. वीडियो लास्ट में देखेंगे अगर है तो, नहीं तो I will share the video with all the audience. That way. So basically, it is just the same no-touch technique like we do in interval, and we clean the cervix with 2 gauzes of. This is for infection prevention. After delivery, again we clean the cervix, and we grasp this anterior lip of the cervix with the ring forceps, and basically the insertion. What is important is the insertion angle, the angle of the uterus while we are inserting, and that we reach the fundus. We have to make sure we are not at the angle of the uterus, and while coming back, we open the forceps properly and sweep it along the lateral side. So it is basically even the expulsion will depend on the expulsion rate. People used to think that PPIUCD has a very high expulsion rate to the tune of 16 to 20%, but no, neither does our data say this. Now we have first-hand experience of PPIUCD insertions, nor does the larger data say this. Of course, as long as, just like in interval IUCD, we used to say if the provider is not skilled, then only perforation will happen. Otherwise, perforation is almost zero. Similarly, if we have a trained service provider, the expulsion rate is at the most 4%. So definitely more than interval, but 4% is quite acceptable because we are saving 96% women. So these are some of the steps that I just wanted to say that one should keep the forceps open while sweeping back, and we should straighten the uterus properly. And when we are inserting the ring forceps, the angle should be towards umbilicus. These are the tricks that do the retention trick that is there. So then we do little bit of documentation, because CAB register also has a column for PPIUCD. There is a service delivery master register recommended by Government of India. There is a IUCD card recommended, so we just hand over that later on. And a client exit interview will give us real reassurance that we are satisfying the women. So there is little bit of course, counseling is as important as an interval this thing, and we have to give her ongoing support. She should come back to us with a problem. Maybe we can leave a phone number with her. Maybe she should know who is the Asha nearest who can help her out with any problem. We should give her a follow-up stamp that come back at 6 weeks, and we should coincide that postnatal visit with her immunization visit, so that she doesn't have to leave home for more than one time. So that is how. So retention, as I said, depends on these things. If we support her post insertion through ASHA, through peers, through relatives, through our own system of follow-up, we can even take telephonic follow-ups. So that gives us. So this I almost already discussed. These are the tricks of good insertion. So the right time, the right instrument, and the right technique will give us good. This is an algorithm that we have made for PPIUCD, how to go about and how whose role at what stage, and how to report. This is little to make documents. So this is what I was talking about, the poor contribution of private sector for various reasons. Maybe it is my own failure. I have not been able to reach out to individually. I have reached out to some of the hospitals, and they are the ones probably contributing to this. Some others, but now from here onwards, I really want that at least we maintain a similar percentage coverage of deliveries in private sector also. After all, women are the same, the counseling points are the same, the time we give, in fact, in private sector, we give so much extra time to women rather than what we are able to do in our public sector. So over the last few years, we have been doing, say, 40 to 50,000 of PPIUCDs. That is about 18 to 25% of deliveries that we are conducting. Private sector, it is less than 1%, and so the contribution is also less. And I already said about 20% of our deliveries are in private sector. This is Delhi data, and this is how when 2010 we started doing this, we had a frog leap, and we were appreciated by Government of India for this. Delhi was appreciated for taking up PPIUCD so well. Then there was a plateau at 20%. We plateaued 19 to 21%, and now in the COVID times. In last year also, we tried again to come up from 20 to maybe 25%. Some of the hospitals gave us good support, and we came up to 25%. But as soon as the lockdown was announced by PM Sir, I was worried about my program, and I sent an advisory that we have to take care of IUCD insertions during delivery, because interval IUCDs is really going to have a backlash. So with that, we have reached 30%. So probably that is the side effect, or that is the hidden beneficial effect of corona, that we have become more sensitive to postpartum contraception. In this. So this is how, this was the response to my call that came from my hospitals. Many hospitals who were doing around 20% came up to more than 50%. And those who were doing 10 to 25% came up to 25%. So most of my hospitals are above 10% now, and you can see many of them above 25% also. And we are working on the less than 10% hospitals now very vigorously. So that is the need of the hour, enhance the coverage of PPIUCD. The benchmark of Government of India earlier was 25%. It was telling all the states to come up to this benchmark. Now my new benchmark is 50%. And PAFP, just a remark on that, we should take care on PAFP also, and there we'll be able to save some unwanted pregnancies. So we should make 100% post-abortion family planning. Every woman that who aborts in a CAT center, we must make sure that, and there are so many webinars from Foxy, and there is so much focus. I'm so glad all the forums I'm hearing about CAC services during COVID era and about post-abortion family planning. So I'm sure we will be able to save India from that baby boom that everybody is talking about. certainly my concern is Delhi women. So this is the impact on PPFP. I already said we were somewhere at 20% for many years, and then we started working on it, and gradually from February to June we came to 25%, and now we are almost, this June data is not very complete, May data, the start part. So this also I'm expecting that we won't fall below 31%. So obviously, with more hospitals joining in, we will increase this. This is what everybody should, strive towards. And this is the quality, for the quality services. We already have these SOPs from the government of India. So we have all the guidelines, everything is there. Nobody can tell us that this is a wrong strategy. And then there are strategies. This is especially for the private sector, because this is how I inducted this program in our sector. Some of our medical colleges with heavy labor rooms were far behind in the initial years. So this is how we started these strategies. Lately, Lady Harding has come up from less than 10% to almost 20%. So these are the strategies. You have to pre-sensitize the senior residents before they go into labor room posting, and recognize their efforts. If they are taking efforts and they are accomplishing that during their duty, they are doing good. They are covering good amount of women with PPIUCD. So these are some of the strategies we have to coax them to work and then felicitate them, recognize their work. So, and of course, there are other strategies like, putting the algorithms, putting a lot of IEC material, roping in everybody. It's a teamwork. Initially, our nursing orderlies used to, when they used to wheel in the patients, they used to say, "Aajkal PPIUCD bahut chala hua hai, bachna usse." I've heard people talk like this. So you have to have rope in all the people and tell them. Yesterday only, BDO Hospital has done a very beautiful skit on this, and I could see the party that it was choreographed by a nurse. It was, somebody, nursing orderly is singing, the male nurse is acting. So it was a beautiful teamwork, and that is how the message percolates down.
Dr. Jyoti, just sorry to interrupt, but we are not able to see your face at all. It's covered by your hand and
okay, but you wanted the mic to be there.
Yeah, actually the profile picture is coming.
Okay.
We're not able to see you at all.
Okay.
So can you face the screen? Can you face the screen? Yeah, that's nice.
So maybe you can now see the passion. There's nothing or kuch nahi hai, but it's basically the passion on my face with which I really want the same commitment from my audience. I'm taking this opportunity to convey my message through AOGD platform. And similarly, if we come to the PPS data of Delhi, the private sector is much better there. I think cesarean ligations they are doing wherever they are getting opportunity. And this is what the data talks, that we are also looking at postpartum contraception through permanent methods. But of course, PPS has suffered during the lockdown period. I hope now I'm both audible and visible. So coming to the next important postpartum contraception, that is the MPA. So this is another gift that Government of India has given us in the basket. And since this does not have any effect on lactation, this is really a very good opportunity. And if we are not able to give the woman anything within 10 minutes or by the time she gets discharged, 48 hours or whatever, then at least she should be given a leaflet on this Antara program and MPA, that you come back at 6 weeks and beta take this injection, and this will save you from a lot of maternal morbidity and a lot of maybe mental trauma of too early another child. So mechanism of action, I will not go into detail. There are lots of myths and misconceptions that we must take care, especially the ones people think that there will be a lot of menstrual problems. So a thorough counseling will do the job. So before she goes home, at least she should decide that, okay, I have not taken Chaya, I have not taken POP for whatever reason. I have not taken PPIUCD, I have not got PPS done. I am coming back at 6 weeks for MPA. So that should be the outcome of the counseling that started in first trimester. So, and follow-up, of course, is important. And one thing I would like to say that in post injection counseling and during counseling, I always, when we had trainings on MPA, I always said, although there is a 4 weeks window period, do not start with that in counseling. You say the date is important. However, if you get late, we are there up to 4 weeks, because if the message goes, just like in OCP, if the message goes that if you miss, then you can take 2. Then she thinks that I have to forget sometimes, and then I have to take 2. Similarly, if the message goes, she thinks I have to come after 4 months. So we should say that this is the date you have to come back. By chance you get, but in COVID times, she has to have that reassurance that there is a 4 weeks window period. So here maybe the counseling little bit can change, that if you are not able to come, there is a 4 weeks window period, and if you want to come, you can come few days in advance, even 2 weeks in advance. So we are here becoming more flexible during this time. So this is Dr. Shailaja, one of the our hospital's HOD gynae, and we have been trying to say that let us not have new MPA injections. That's what the entire state data in Government of India says, that there are lots of first injections, but second, third fall. The follow-up rate is quite low. Fourth injection, it is less than 5%. So these are some of the tracking strategies. Just like you have a tickler bag for immunization, we said either make boxes or this. This is the beautiful way of reminding your women. And since now we are doing so much of teleconsultation, why not call them up and say that, beta, this is due. Your reproductive intention was to delay pregnancy for 3 years, and now you are not coming back after third injection. So this is one of the strategies I wanted to show. Very useful for postpartum women who generally forget. So next option is oral pills. So we have 2 options. The combined pills after 6 months, and progesterone only pills, and Chaya is there. Thankfully, both these, one is already there in our basket. The POPs are, in line. Probably it will, but how long is that pipeline? I do not know. But still, we should talk of this, because in private sector, I think Cerazette is quite popular, and it is very much affordable to the women who attend private sector. So that is why we will talk of all 3 options of this in postpartum period. Failure slide pehle laga di. Anyway, we know that these are all very effective if perfectly used. So these are good options, and I will not be talking much about their mechanism of action or anything, but some important points in counseling, that the timing of taking POPs is important. There will be there will be some menstrual irregularity, and the menstrual control is not as good as combined oral pills. So this is how it's a 28 pill packet, same pill in all 28, and the one available and more popular is of course desogestrel, because earlier mini pills had much more failure rate and less of window period. So Cerazette is the one which we are recommending, and that is the one which will incorporate in the Government of India basket. And also advantage of Cerazette, that it also suppresses ovulation, besides the other 2 things that earlier mini pills were doing, thickening the cervical mucus. And so the key benefits are that it does not affect milk production. That is why the relevance in postpartum period, and does not contain estrogen, so related side effects will also not be there. And it is safe and MEC criteria 1 or 2 for most of the things. In fact, it has been switched from MEC 2 to MEC 1 in the updated WHO MEC criteria. So when and how to start, I said it can be started as early as in labor room, and any time after that. If the periods have not returned, then we give a backup period, and of course we rule out pregnancy with the algorithm that is available. Limitations, of course, one is, I said, a little bit of menstrual irregularity, which that pattern varies in different women. But if we have done a good pre-counseling, then that is taken care of. And little bit of side effects, much less than combined oral pills. There may be headache or dizziness in some women, and of course the prolongation of the period. So this is the algorithm on how to manage the missed pills. This comes last in my counseling, because but of course this algorithm should be available with all service providers, so that they very aptly manage the missed pill and do not let the woman land up in a pregnancy or failure. So this again I'm not going in detail. this also I think all of us are familiar with. Chaya also, I said we can start in the labor room. We all know it's a non-steroidal Indian product of made in Lucknow, and the constitution is orviloxifin, and it is very relevant in breastfeeding women right from day one. It is taken. Do you want me to go into the details how it is taken and how? Because I think I'm taking longer than my allocated time.
Dr. Mala? Dr. Mala?
Yes, Budia.
So just, okay, probably this is almost the last, my conclusion slide has gone. So we all know we have to start on day one of the periods, or if she's breastfeeding and she's delivered day one of delivery, she can start. And then it's bi-weekly for 3 months, and then 4th month onwards. Switching should be made very clear to the woman, because most of the failures that we have seen in the field happen during switching. She's not able to switch properly. So the switching at 4th month is important, and there should be no missing the tablet. If she misses, we know what to do. If it is less than 2 days, we can just give her that extra tablet that she has missed. If it is more than 2 days but less than 7 days, we give her backup. More than 7 days, she starts again with that bi-weekly schedule. So all that should be clear. And just my message that postpartum contraception has assumed much more importance during this COVID era, and we really need to tap on this opportunity of women coming for institutional delivery to the institution, because at other times this really may not be the priority. We are really suffering on interval services. So probably, as I said, 100% in post-abortion family planning, we should give something or the other. 100% PPIUCD nahi hoga, but 100% postpartum contraception we should give to the women. That's my concluding sentence. Thank you so much for giving me a patient ear.
Thank you so much, Dr. Jyoti. That was such a passionate talk. We were just discussing that you're telling everything so passionately. We can make out how much you're into the subject with heart and soul. It was a very nice talk, and I'm sure many of the concepts and the doubts would be cleared of the audience. Yet, if they have any queries or any questions, we can take them up at the end of the session. So, thanks a lot. And I would now introduce our Dr. Mala. Dr. Mala?
Yes, bolo.
Yeah. Shall we go on with the next talk?
Definitely.
Okay. So I would like to introduce our next speaker of the day now, Dr. Shobha Goody, ma'am. Can we have the slide, please, Ms. Richa? It's my honor and privilege to be introducing Dr. Shobha Goody. She is a gem of a person, and I had the opportunity to work with her under her guidance in the Surakshit Naritwa national program. And she is really a very nice lady at heart, apart from being a very excellent academician. So we welcome you, ma'am. Dr. Shobha, why is the slide not showing up?
Ma'am, Dr. Jyoti has to stop sharing. I cannot share till the time she's sharing.
Okay. Dr. Shobha is the professor and head of department at St. Philomena's Hospital, Bangalore. She is the chairperson of the Family Welfare Committee, FOXY, 1990-1921. She is the secretary of the Bangalore Menopausal Society, and she is the chairperson of the Family Welfare Committee, FOXY, 1921. And she's the assessor for Lakshya, board member of FPAI, peer viewer of the Journal of Gynae GOGI, and she's a very distinguished DNB teacher. We welcome you, ma'am. And ma'am would be speaking on the expanded basket of choice for the private sector for contraception.
Yeah.
Over to you.
Am I audible, Kanik?
Yes,
Yeah.
ma'am. You're very much
Yeah.
audible.
Okay.
You're nicely audible, Dr. Shobha.
That is the whole idea. I was just telling Mala that, for Mala or myself, there is no problem about volume of voice. We are established sirens in Foxy. So, a very good evening to AOGD. And it is fast becoming my favorite society, Mala, thanks to you and your beautiful team, Kanika, Mamta, everybody. And Kanika is very right. We really had a lot of fun during Surikshit Naritva. We enjoyed, organizing and conducting. So I must speak to you about contraception, the expanding the basket of choices. Am I audible to the audience? I hope
You're
no
very audible,
difficulties.
doctor. Clearly
And
audible.
I will be moving a little fast because I did not expect that I will be beginning at 5:30. I thought I will begin at 5. So therefore, there will be a little speed. So kindly be attentive, and the question answers can be later on directed. I will be very happy to answer. So this is in context, setting the context for the talk. We should all be aware that we can make a lot of difference to this need for population stabilization and the world population at the growth that it is happening despite the pandemic. It is currently 7.7 billion, but at the rate that it doubles, we will be 12 billion by 2100 in a few decades only. And we as a country cannot afford it because our density is anyway very, very high. So though we are the second most populous country with 136 crores, yet we are very dense, and we may surpass China by 2024. So with that context, let us understand that there is a very high uh, percentage of pregnancies which are unplanned, unintended, unwanted children who are conceived, and that should not happen because 1/3 of them end in reproductive wastage. They end in abortions, and that also puts a heavy strain on the abortion services in our country. And the estimated rate of unintended is 70 pregnancies per 1,000 women in the reproductive age. Ideal would be 0, of course, but at least 10 to 15 is manageable. Now, it is evidence tells us, and we need to learn a lot from what research has shown, that if we offer modern contraceptive methods to fulfill the unmet need, then 2/3 of the women are satisfied with these methods. They do continue, and the 19% of unmet need will be met. And the contraceptive prevalence rate, which is 40.4% right now, will cross 70%, as is, required to meet the unmet need. So increasing the choice will hopefully result in increased uptake of contraception. This is how the older basket looked like. You're all familiar with this, and Dr. Jyoti has very beautifully told us that what are the options available for the woman today in India. Apart from the sterilization and the barriers, we have the hormonal devices, the injectables, the intrauterine devices, of course the LAM method, and then there are many things which are missing also. I must tell you that implants have been there for a year in our country now. They are available, but then training for it is lacking, and it needs to have a kind of drive or an impetus. Female condoms are some methods, a type of method which needs to be highly, highly promoted, so that the woman becomes more autonomous and she feels empowered with the, by having the control for the act. And the natural methods need to be propagated, and of course the non-hormonal contraception, centroman, though strictly it is not non-hormonal, it is at least non-steroidal. So this is the effectiveness chart. Just now, my previous speaker has spoken about this. Now, each practitioners should have under the glass top table in the clinic, and the arrow should point towards us as we are sitting. That means that the chart should be towards the patient, and she should immediately make out that the top of the arrow is the most effective method. So apart from sterilization, methods which give equivalent benefit are the implants, the IUDs, and then come the injectables and the hormonal, and then the rest of them. So on the right hand side of the chart is also given tips, which one-liner tips, which will help in improving the efficacy of this contraceptive method to the maximum. To give one example is, must take a pill or must wear a patch or a ring every day for the contraception not to fail, something like that. So that is very, very important. Now, COCs or oral contraceptive pills have seen an evolution over the last 20-30 years, and today we have the most modern pill with us with very, very low dose of hormones in them, and these are all very gone through phased research and are available for use in the pharmaceutical therapeutic circles, and we must source them, we must use them properly. So the combined estrogen progesterone is there, progesterone only is there, and these pills can also be used in the continuous or extended regime. Of course, we all know how it acts. There are 4 ways in which it acts, but one significant way that we need to remember is it also increases the SHBG level, and it also increases the clearance of testosterone because of this, and therefore the unique anti-testosterone, anti-androgenic properties, which are very, very useful for women for giving benefits beyond contraception. Now, here in this slide, let us focus on the 4th generation COCs, which are the latest ones. And they contain either desogestrel or gestodine in the 3rd generation. Of course, we have the desogestrel preparations for 20 or 30 micrograms ethanyl estradiol. Then we have the 4th generation, which has drosperinone or Dynagest or normegestrol. So we have today drosperinone with ethanyl estradiol and Dynagest with estradiol valerate. These pills are already there with us. Let us understand what is meant by low dose COCs. We come across this terminology every day that, okay, for this woman, low dose COC is appropriate. Low dose is those preparations which contain equal to or less than 35 micrograms of ethanyl estradiol. And we call them low dose because they have the least possible dosage of estrogen, which is the troublemaker for long-term COC users. So if we have low dose pills as prescription, then the risks of DVT, the thromboembolism, the arterial thrombosis, etc., plus the risk of cancers, cardiovascular disease, etc., are minimized to the least. Different regimes of COCs which with we have to be familiar. You can see on the left hand side the traditional regime of 21/7 and 24/4. Let us understand this 24/4 because 21/7 already you have been using for several years. Now the current concept of 24/4, in order to feel convinced that it is good for your women, you must understand that this regime, though it gives a lower dose of estrogen and progesterone, because it is being given for 3 extra days, it actually reduces the hormone free days for the woman, and therefore also reduces the withdrawal symptom, and therefore also gives better cycle control and better acceptance of the method with lesser symptoms of hormone withdrawal. The extended regimes and the continuous regimes are used for those women who have additional requirements of symptom relief apart from contraception, like prolonged bleeding, irregular bleeding, treatment of various types of AUB, EO, etc., and also for women with endometriosis, etc. So there are a whole lot of women for whom extended continuous regime are applicable, but for contraception, traditional regimes are useful. So WHO MEC criteria is a mantra which you have to keep in mind, you have to keep on the desk, and you have to constantly refer to while prescribing contraception. And 1, 2, 3, and 4. 1 is you can use that method in that life phase of women for that condition. Second is when the benefits are outweighing the risks for that method for that condition. 3 is when it is suitable, it is preferable not to use the method because the risk outweigh the benefit. And 4 is when that method for that life situation should not be used. So to take some examples of the WHO MEC criteria applicable to COCs, let me just take one example in each slide. There's no time for more. Let me consider a woman who is more than 6 weeks but less than 6 months postpartum, and she is breastfeeding, and in her is COC possible. So in these women, COC cannot be given. The combined estrogen contraceptive, progesterone contraceptive methods cannot be given in breastfeeding women. And we have to wait for 6 months to be over, then it becomes category 2. But inside 6 months, after 6 weeks, it is category 3. And inside 6 weeks postpartum, it is category 4. So that is how MEC criteria go. One more example would be a woman who is more than 21 days to 42 days postpartum. Okay, the 4th row. And, she has, let us see the 3rd row. She has no other risk factors of VTE. meaning that she is not obese, she is not old, she doesn't have previous history, she has not had any thrombosis in pregnancy or any other time, or no family history, etc., etc., no Apler syndrome. So in these women, if they are more than 21 days and to 42 days, it is MEC category 2 to use a COC, provided she is not breastfeeding. But if she is more than 21 days within 42 days, the same time interval, but does have any of the risk factors which I have told you, then she becomes MEC category 3. So these are the ways in which we utilize the MEC criteria to prescribe low dose COCs. And this is about the POP method. And here, if the woman is less than 6 weeks postpartum, let us see how progesterone only contraceptives, not only the POP, how POCs or ETG, the etonorgestrel implant, or the LNG IUS or the POP. Now, all these methods become MEC criteria 2 before 6 weeks. Just like Dr. Jyoti also said, that today there is a list of contraceptives which can be provided to the woman before she gets discharged. That means she can start the method before she goes home. And you can just list it off today. The copper IUCD is 1, 380A. The LNG IUS is the second. Third is the progesterone only pill. Fourth is the centrochroman method. And the fifth is the implant. So all these methods, even in breastfeeding women, can be given with MEC category 2, less than 6 weeks postpartum to breastfeeding women. Okay. The only exception for category 3 of progesterone only injectables is not given earlier to 6 weeks, because there will be some concern about its effect on the breast, on the lactation, etc. Okay, so this is how the benefits and the minor side effects look. You all are aware about the minor side effects. You all know that they do go away after few cycles of use. So counseling will take her through them. The benefits are tremendous, should be highlighted: good cycle control, good relief from menstrual symptoms, acne, hirsutism improve, bone health improves, prevention of cancer is a reality. It is evidence, it is concrete evidence that ovarian, endometrial, colorectal cancers are reduced by more than 50% in women who use COC for 3 to 4 years at least. It therefore reduces maternal mortality as well because of the low incidence of failure, which is less than 1%. And a question which often plagues the mind of all practitioners: what about thromboembolism? What if she suddenly lands with a pulmonary embolism? What if she throws an embolus and blames me for that prescription? So I have to tell you that VTE incidence, if you look at women who are put on COCs, is 8 to 10 per 10,000 women years of exposure. That is how it goes, the established incidence of venous thromboembolism in women who take COC. And if you look at women who are not on COC, not on any contraceptives, then the risk is lower than this, of course. It is 4 to 6 per 10,000 women years of exposure. So that means it is not zero for non-contraception users. And if the women are pregnant population, then the risk of VTE per 10,000 women is 10 to 14 at least. Some say even 15 to 20 per 10,000 women. So the risk in pregnancy forever remains higher than the women, those populations which are on hormonal contraception. So that helps us in counseling. And this remains true of whichever estrogen progesterone combination you are using, whichever is the newest progesterone molecule you are using, it remains the same. It has not shown any statistically significant difference between different progestins. Okay, myocardial infarction and stroke happens to be arterial thrombosis in these women, and it is 1 to 4 per 10,000 women years exposure, and it actually is not very much higher than the age-related incidence of these vascular happenings in these women. The risk for VTE appears to be highest in the first year. So if our woman sails through the first year of COC exposure without any thromboembolism, she is unlikely to have it again. Okay, so that is what I wanted to tell. These are something which I will skip, I think, because the time is not there. I would just like to say that the risks associated with progesterone only pills also, we have to exclude acute or recurrent DVT, though the past history of DVT does not is category 2 for POPs, but category 3 for estrogen containing compounds. Liver disease and breast cancer, of course, are also contraindications for progesterone only. These are studies which support that there is a very, very low risk of pregnancy in women who are on COCs. Now, let us come to this concept. This is one concept that all of us should understand today, and that is what is SARC method and what is LARC method. So far, whatever I have discussed, as well as the patches, the rings, are all SARC method. They are short-acting reversible contraceptives, and they are heavily user-dependent. That means in order to not become pregnant, the woman should use it correctly, and the provider depends on the woman's compliance. The inconsistent use can lead to high failures. There has to be more counseling, more effort, more follow-up, and the fear of negative health effect. And the moment she falls ill, any concurrent illness or infections go on, she's likely to stop these SARC methods and she might fall pregnant. So these are the difficulties in service provision in SARC, whereas LARC is our best friend. LARC is a gynecologist's best friend. LARC is a client's best friend. LARC is a real breakthrough for contraceptive services, right? LARC offers highest protection against pregnancy, less user error, high satisfaction, low failure rate, ease of user. LARC methods are all estrogen free. That is very, very important. They're all estrogen free, and estrogen is primary hormone for thromboembolic events. Therefore, you know, you can be very sure that if she is obese, she's smoker, etc., it's much better to have a LARC method. The other way of looking at LARC is, of course, what is highlighted here says that, you know, there is a more nuanced information regarding the risk and benefit of effective reversible contraception. Okay, can help women in making informed decisions and gain a higher quality of life. So our information, our counseling has to really improvise. Now, one factor about LARC, before I quickly wind up by telling you the two new LARCs in the market, is that there is a kind of saying which goes like this about fit it and forget it, or provide it and forget it. And that is how the provider can look at it. Most often, the woman requires follow-up, but you know, it can be sorted out over teleconsultations. And if you fit a copper T, you can forget it about, you know, giving any major intervention to the woman for the next 10 years. That is how good as it goes. These are the methods, of course, the copper, the LNGIUS, and the DMPA, and the progesterone only. Subdermal implants, and these have less than 1% risk, 1 per 100 women years, a very low Pearl index, almost as good as sterilizations, and almost all authorities endorse that LARC are good methods. The NICE, the ACOG, the FOXY policy statement also says the same thing. We come to this newer development in the injectable contraceptives. You just now heard everything about Antara by Dr. Jyoti Sachdeva. I want to tell you that this is how it works. DMPA, of course, I need not go on this slide. These are the contraceptive benefits, which again, we have kind of gone on telling you that how good DMPA is. The one thing which I must tell you, that it is a very private and confidential method for the woman. She feels very comfortable taking an injection every 3 months because the family will not come to know if she wants to keep it confidential. And these are the non-contraceptive benefits, which I have already, you know, in addition to reducing breast disease, uterine disease, benign ones, and pregnancies, minimal drug interactions, and reduced incidence of ectopic endometriosis and PID, etc., as well as cancers, as well as sickle cell crisis reduction. So these are the benefits of DMPA. I must tell you today that we are looking at a 30% cut in the dosage of that 150 milligram, and you can provide the woman with just 104 milligrams subcutaneously. That means we give her once, and later on you give her a filler prescriptions, either when she comes the first time or by teleconsultation. You can give her a fill-up prescriptions to take every 3 months, every 12 to 14 weeks. If she takes, she can easily have 4 or 5 injections like that. She can self-administer because now it has become subcutaneous, and it is a disposable one, pre-filled syringe, which is very, very easy. It looks like this. It's not very expensive also. It's 500 to 600 rupees. So she can herself inject subcutaneously every 3 months, approved by the DCGI. It is eco-friendly, all-in-one presentation, slower and more sustained absorption of progestin. In general, it has got the same, efficacy as the 150 mg with a lower dosage. So in conclusion, highly effective, convenient LARC method, good tolerability profile, and it is very, very possible that those troublesome instances of spotting, etc., might become less with this method. We come now to this method of implant, which is, I have already told you that it has been there in the Indian market for the past 1 year. It is a disposable preloaded applicator with a radio opaque nature of the device, which makes it easy to be tracked by imaging. This is how it looks. It's 4 centimeter and 2 millimeter. And it has got a core with the drug and the base around it, which allows the rate control or release. And it is single use and disposable, costs around 3,000 rupees or so. And the service charge, you can add a little bit to that. And we need a small training session for this. It gives a very good plasma level of etonorgestrel. And, even in obese women, it does give benefit for 3 months or so. But then in the 3rd month, it might become a little less. So we have to be on the lookout. Mechanism of action is it inhibits ovulation and acts on the cervical mucus. Some adverse effects are reported, especially irregular bleedings, but in about 5% of subjects. With good counseling, they do get over it. And complications of insertion and removal can be much minimized by good training. And there can be some fibrosis at the site, paresthesia, very rarely intravascular migration because it is improperly placed. So contraindications, as we have checked out for other progesterone only methods, if there is drug sensitivity or malignancy which are steroid sensitive, or thromboembolism actively present there, or liver disease present there, or undiagnosed vaginal bleeding, etc. Drug interactions are possible. Unlike the injectable DMPA, this particular drug, like the estrogen containing COCs, has some kind of reduction in efficacy if the woman is concurrently on anti-epileptics or HIV medication and some other enzyme inducers. So we have to be very careful about that if the woman is on concurrent medication. This is a simple tray which is required. And this is how the woman is made to lie down after consenting. A local anesthesia is given, and it is the underarm, and it is about 8 centimeters from the medial epicondyle, and the insertion site is actually between the triceps and the biceps bellies, and it is away from the neurovascular bundle. And we do mark the 2 spots like that, and the device is, the plastic cover is removed, and the insertion needle has got a bevel of 30 degrees, and it is introduced just beneath the skin and then lower to be horizontal against the arm, and the skin is lifted up and the device is delivered. It's a very simple technique, but it requires some orientation and a small training session. And during the entire procedure of insertion, which hardly takes few seconds, one should be sitting down beside the arm of the patient, keeping the eyes at the same level. And after the insertion is over, we need to palpate and verify that the device is in place. So this is all the lecture could hold today, this much information only. Family Planning 2020 commitment was very, very grandiosely planned by the government, in which they said that they will increase the MCPR by 0.4%, thereby taking the mean contraceptive prevalence rate from 53.9% to 54.3%. And this would require service provision to about 50 to 60 million women. And this all had been planned, and it has been impacted by the pandemic. But we are still hopeful that if not 2020, maybe this will be achieved by 21. And the government basket has also increased in the past 2-3 years by the POPs and the Chaya, the Centroman, and so also has the private basket. So delivering quality assured services to the hardest to reach in rural and urban areas is the motto for all providers in this sector. And increasing awareness and demand through 360-degree communication campaign rolled out across all states of India is also the FOXY mission. So today I stand before all of you and I declare that from the Family Welfare Committee FOXY, we have initiated a lot of small group discussions, which our members are taking, my committee members are taking them across India. We have initiated poster presentations. There is a competition for slogan and poster, which I have posted to my dear friend Mala, and I hope that she will she will alert the postgraduate force in AOGD as well as the young consultants to come forward and participate with your innovative ideas on those posters. And also, please take forward postpartum contraception in the form of PPIUCD. We do have more and more plans for this committee, and please support me in your everyday practice by working for Family Welfare Committee FOXY. All you have to do is to look after the SRH needs of your women, and automatically there is a lot of blessing which comes in from the Almighty, because that indeed is the need of the hour, and that is requirement of 100% of all our women. Thank you very much, Dr. Mala and team, for giving me this opportunity to address my favorite society, AOGD. Thank you very, very much.
Thank you very much, Dr. Shobha Gudi, and thank you for addressing us as your favorite society. We are honored.
Thank you.
And it was indeed a very enlightening lecture and very timely wrapped up. We've got the gist of it, and at the same time, it's been done rather fast, and yet we could grasp each and everything.
Sorry.
Very, but it was
I had to keep up the speed. Yeah.
No, because it was clear. Nothing was.
Thank you very much.
So I now invite the next speaker for the day, Dr. Anita Rajoria. Dr. Rajoria is the Head of Department Obs and Gynae at Sardar Vallabhbhai Patel Hospital, Government of NCT Delhi. She is the chairperson of the Reproductive Endocrinology Committee of AOGD. She is a member of the FOXY Endocrinology Public Food and Welfare Committee and Breast Committee. And she is a Wanda Foxian, an inspiring gynecologist. So I welcome you, ma'am. Dr. Rajoria would be talking on the return of fertility after hormonal contraception. Over to you, ma'am.
Presentation. Presentation खोलो पहले. Just a second.
Sure. Ms. Richa, if you could please help Dr. Anita.
Yeah. I'm starting the presentation.
Okay.
Can you see my presentation?
No, we can't see the presentation as yet.
I'll share it. Okay. Share screen.
You have to go to the screen share.
Yeah.
Yeah, we can see it now. We can see it now. You have to unmute yourself, Dr. Anita. You have to unmute yourselves. You are muted.
Yeah. Can you hear me now?
Yeah, you're audible.
So after the stalwarts talking, I'm going to continue the discussion about return of fertility after hormonal contraceptive use. Next, you. So the truth is, women use contraception not as a way to prevent unintended pregnancies, but also to improve their health and health of their families. Increased access to contraception has led to decline in maternal and infant mortality. This was rightly said by Felicity Huffman. So the need of contraception has already been highlighted by my previous speakers. World population is expected to reach 9 billion by 2050, and India is going to contribute 17% of the population. Now, this was the pie chart that showed contraception utilization in India. We can see that hormonal contraceptive use is very, very less. Regarding pill use, it is just 4.1%, and injectables are much lower. It is just 0.2%. So what is the factor which are leading to these lesser use of hormonal contraceptions in India? Are there some factors underlying these? There may be myths which are surrounding the use of hormonal contraception. So can we do something about these myths to create, clear messages to the masses? So what is the myth? The myth is prolonged use of oral contraceptives or other hormonal methods might delay or permanently impair future fertility. So is there a link between long-term use of oral pills and delayed return to fertility? This issue has to be addressed. So along with increasing availability and utilization of contraception, it is also important that the effects of contraception use on resumption of fertility after discontinuation is estimated. And resumption of fertility after contraception use, however, have been inconclusive till date, and practically we are not able to address this big concern of women. Therefore, we understand that estimating the rates of resumption of pregnancy after contraceptive use from the available reports and identifying the associated factors are important for designing a strategy to overcome the problem. Do OCPs really result in a delay to return infertility? For one to make a valid comparison regarding return to fertility after oral contraceptive use, we have to understand normal fertility and fecundity of a woman. In the general population, the average time for a couple to conceive is approximately 6 months. Couples are not considered to be fertile unless they have tried to conceive for at least 1 hour. There have been concerns about a possible correlation between duration of oral pill use and impaired fertility, but evidence regarding this is lacking. A comprehensive survey of the reported data suggests that return to fertility associated with the cessation of oral pills is generally similar to that observed with other common contraceptive methods, both hormonal and non-hormonal. So what is the evidence talk? What do clinical evidences suggest? Are OCPs likely to be endorsed for use of women or not? So this was EURA's OC study. What is EURA's? EURA's is the European Active Surveillance Study on Oral Contraceptive Use. They estimated the time of conception following cessation of oral pills with the intention to get pregnant. So these were the cycles after stopping the oral contraceptives, and these were the pregnancy rate achieved in percentage over the time. So we can very well see that 25% of women became pregnant within 2 months of stopping their oral pills, and almost 50% had conceived within 4 months, and 80% patients had achieved pregnancy within 1 year of stoppage of oral pills. Progestin type, ethinyl estradiol dose, duration of oral contraceptive use, and parity had no major influence on the rate of pregnancy after oral contraceptive cessation. So it is likely that we can endorse use of oral pills for our women. This is the forest plot showing the rate of 1 year pregnancy following discontinuation of contraception, which was rated according to the random effects model. So in majority of the studies, after 1 year of trying, patients were able to conceive in in 76% to 86%, and all the studies almost showed the same results. Systematic review and meta-analysis. This was PRISMA. PRISMA is preferred reporting item for systematic reviews and meta-analysis. So according to this systematic review, 83.1% of women who discontinued contraception became pregnant within the first 12 months. Analysis reported higher rate of conception, which was 87% after cessation of oral contraception. Progestin type had no significant effect on the rate of pregnancy over the short-term and long-term OCP use. Other than duration, dose of estrogen and progesterone did matter, but we are not, concerned about this because currently we are using only low dose preparations. In addition, return of fertility among women discontinuing after extended or continuous OC regime is similar to those observed with cyclical intake of oral contraceptives. So this is, the meta-analysis, they tabulated it. The median time to pregnancy in women who conceived within 1 year of stoppage of contraceptive is consistent with those reported of women who are not using any contraceptive. So you can very well see that they had taken oral contraceptive here and all other were compared, like copper intrauterine device, LNG system, implants and injectables. The mean exposure time which the women were exposed to was 1.7 to 7 years. And mean age of discontinuation was 26 to 28 years. And they get 1 year pregnancy rate after stopping the pills was in 79 to 95% of women. And mean time to achieve pregnancy was 2.5 to 3 cycles. So these results were comparable in all, and copper intrauterine devices also showed same results, that 71 to 91% of patients, they conceived within 2 to 4 months of stoppage of discontinuation of copper intrauterine device. Similar was the finding for LNG IUD. This was the mean exposure time for women were 1.9 to 2.5 years, and 26 to 27, this age was comparable in all the methods used. This was kept as a similar comparable variable, because with increasing age, women as such have reduction in fertility. So in all the studies, the comparative age groups were there. So after stopping of LNG system, 79 to 96% women had achieved pregnancy in 1 year. But there was some delay found in conception. The interval was up to 4 to 7 months. Similarly, implants had pregnancy, median time to achieve pregnancy was 2.9 to 7 months. Same was with injectables, and the woman was able to achieve pregnancy within 4 to 5 months of stoppage of that method. So what will you counsel a woman prior to OCPs, besides explaining her all the pros and cons of using oral pills? You are going to counsel her about return of fertility if she is willing for further conception. So what will be your points? Resumption of ovulation and ability to conceive after cessation of oral contraceptive use is a major concern for women. Women may believe that oral contraception impairs future fertility, and they may prevent the woman for achieving pregnancy after discontinuing its use. Some women have a myth, they take pill breaks in the erroneous belief that these are necessary to preserve or conserve their future fertility. Cessation of modern day low dose oral pills is not associated with a delay in conception. Your counseling point will be that women should be advised that breaks in COC use in order to preserve fertility are not at all necessary. Particularly, there were some studies which found that restarting COCs after a pill break of 4 weeks or more was associated with an increased risk of venous thromboembolism. And oral pill use does not have a negative effect on short and long-term effect on future fertility. This was returned to fertility. Is it concerned among the users of intrauterine devices, LNG devices? So these are the type of conception in fertile couples. A normal couple who is trying for conception will conceive within 57% couples will achieve pregnancy in 3 months, and within 1 year 85% couples who are not using contraceptives, they achieve pregnancy, and within 2 years 93% will become. So the rates were comparable when the plot was made regarding months post intrauterine device removal, post LNG device removal. You can see two graphs are there. One, the blue line is showing the one with LNG IUD, and the other is with copper T. The rates were comparable, and you can see that majority of the women had conceived within 15 months to 16 months of stoppage of LNG IUD. So the amount of time it takes for a woman to achieve fertility to return after stopping birth control depends on birth control system she is using. She should be counseled that her ability to get pregnant as such gradually decreases with her age, and it can be affected by other factors like other associated comorbidities, or as such poor health or irregular cycles. She should be counseled that after stopping of any type of birth control, she may have a difficult time getting pregnant simply because she was getting older rather than the effect of contraceptive she was using. She should be counseled that combined oral pills, she can get pregnant right away after stopping regular low dose oral pills. About half of the women, they will get pregnant in the first 3 months as shown in the graph, and most women after stopping oral pills get pregnancy within 12 months of stoppage of oral pills. Similar counseling can be done for progesterone only hormonal methods. So it was seen that as soon as she stops using POPs, she can conceive in a cycle or two. But it has been shown that longer time may be taken for depot methods. So to conclude, what are the facts we have to remember for counseling our patient is progestin type, ethinyl estradiol dose, duration of oral contraceptive use have no major influence on the rate of pregnancy after oral contraceptive cessation on fertility of women. It is important to counsel women that prior contraceptive use regardless of the type of hormone use does not have a negative effect on subsequent fertility. They can choose the dose or the duration they want. Return to fertility occurs within days of cessation of all progesterone only pills, and injectables may take a slightly higher time because DMPA as such, if the last injection was given today, the effect will last for 3 months, and after the effect gets weaned off, only then patient will be able to conceive. So the average time may become 6 to 7 months after the last dose of progesterone. The delay following the discontinuation of DIMPA is recognized, but pregnancy rate eventually reach those associated with cessation of other methods of contraception. So that is all I have to say today. Thank you so much. Over to you, Kanika.
Thank you, Dr. Anita. Thank you. Hello. Am I audible?
Yes, you are audible.
Yeah. Thank you so much, Dr. Anita. That was really nice and very crisp and brief and very timely finished, wrapped off. And I think there are a few questions from the audience. So Dr. Mala, shall we start with the question answer sessions?
Yeah, we can do the question sessions. Can take the question
Yeah,
answer, right?
yeah, please check. Most of the people are writing thanks to all the speakers, and they're saying very nicely presented. Dr. Anaisha Raza has said very beautifully explained, ma'am. Thank you so much, Dr. Anita.
Thank you.
Okay, there's a question from Dr. Anaisha. She wants to know if women having PCOD with irregular periods, what contraceptive advice should you give and when?
So PCOS with irregular cycles, I think low dose oral pills are the best for these women. Of course, you will take detailed history and do examination. And if the patient is obese or associated morbid, comorbidities are there, you have to rule them out. And you can very well put these patients on oral contraceptives, which will have dual benefit. They will control the cycles and bring effect on her syndrome also. So I think oral pills are the best. Low dose oral pills will be best. And if the patient is having associated hirsutism or other features, then of course we'll like to give them pills which are containing drospirenone or cyproterone acetate.
Okay. Thank you, Dr. Anita. I think that answers Dr. Anaisha's question. Another question from Dr. Anita. I think it must be addressed to Dr. Jyoti or Dr. Shobha Gudi. There was a discussion.
There was a, I was just 2 days back, there was a very hot discussion on WhatsApp. So this was regarding, they were saying that in some countries, they have started giving DMPA at the time of discharge. And they have had few studies in which they have shown that it doesn't affect the, it doesn't affect the production of breast milk. It doesn't, yield of breast milk is not decreased. So they have started this practice, but of course we are going to follow our guidelines, which are to start it at 6 weeks postpartum. Once the breastfeeding gets established, you can very comfortably give DMPA to the patient. When the patient will get the baby for immunization, we are doing this practice. We are giving, if the patient is willing and has not had postpartum IUCD insertion, then we are offering them Dimpa or Chaya, whatever she wants.
Okay. So I think that wraps up the questions, because most of the people, Dr. Shaija Sinha, most of the people are just praises for all the speakers. So rather than questions, I think all the doubts are clear. Dr. Deepa Mishra is writing, Dr. Gudi, Dr. Jyoti, Dr. Anita, very informative sessions, clearly explained everything. So people don't have much doubts left with your lectures now.
I think all our speakers have done a wonderful job, and all our chairpersons has also done a wonderful job. We had a nice session on update on contraception, and I must thank Dr. Mandakini May to encourage us, Dr. Parag Biniwala, who has also encouraged us in this ECME, and all the speakers, Dr. Jyoti Sachdeva, Dr. Shobha Gudi, and Dr. Anita Rajoria. They have made the topic very clear and crisp. And I thank Dr. Kanika as well as Dr. Mamta, who have nicely conducted this session. And I thank all the delegates who have been logged in and took active participation in this CME. And last but not the least, I must thank Bayer, who has organized this CME for all of us. Over to you, Ruchi.
Yeah, thank you, Mala and team AOGD for having a very contemporary, webinar on contraception, because it is still on. The fortnight is still on. So we have to, contribute towards this cause for the nation.
Dr. Kanika, can I just add one small remark?
Yeah, sure. Why not?
So one thing I just wanted to respond to the only question that came, that is DMPA, timing of giving DMPA. So recommendation, of course, is 6 weeks.
Right.
We were having some of our ESI hospitals giving injection at the time in labor room. So that we stopped after the SOPs and manual came out in 2016. And breastfeeding women, of course, as we have to wait for the establishment, and we give at 6 weeks with the first vaccine. Non-breastfeeding women can be given much earlier. That's not a problem.
Yeah, very true.
Yeah, the second part, most of the comments are coming from my Ayush doctors, whom I made them join this. So we are converging with our Ayush department in Delhi, and there are extra mouths for counseling, and there many of them are providing family planning services. So I just want to return thanks, to all these doctors, Dr. Aisha, Dr. Deepa. And when I was telling you the points of contact, probably I missed out on, and when I was telling you the various trainings on counseling that we have done for dietitians, male nurses, and Mahalla Clinic, ANMs, and all that, probably I missed out on Ayush medical officers. So they are really we are hand in hand in addressing the family planning issues of our women with the Ayush department. So again, through this platform, I would like to thank them for joining the webinar and actually listening throughout. And most of these doctors that you were naming, Dr. Deepa, Dr. Aisha, they are all from our Ayush side. So just wanted to add on to that. And
Very
once again,
nice.
I want to thank you, Dr. Mala, for
That's very nice of you. It's important for we didn't know them, but at least since you know them, it's very important to address. Everybody
Dr.
should be.
I must tell the audience that our leader, Dr. Jyoti Sachdeva, she's very enthusiastic and she's very passionate about, doing family planning work in, all over Delhi. And government hospitals are already in, and we will really request our partners in private hospitals to kindly contribute and increase contraception, counseling, as ma'am has already highlighted. I want to thank Dr. Shobha Gudi ma'am also for gracing the occasion. Really, it was very encouraging for her to, come and grace the occasion. Thank you, Mola. Over to you.
Dr. Mala, unmute yourselves. Dr. Mala. Dr. Mala, I think Ms. Richa wanted to say something.
Dr. Mamta, your last comment?
There is no, am I audible?
Yeah, you are audible.
Yeah, some problem, occurring with my, that's why I'm muting myself throughout. It has been really very wonderful session from all the three speakers. Dr. Jyoti Sachdeva, it was very elaborative review of contraception, and Dr. Shobha Gudi offering the basket, and at the end, Dr. Anita Rajoria did a wonderful job with the topic. So on behalf of AOGD, I once again thank everyone, all the viewers for joining in and making this a fruitful ECME on contraception. Thank you.
Thank you so much, ma'am. And at the end, I would like to thank once again everyone on behalf of Bayer for your time on a weekday and committing towards the topic, which is contraception, which otherwise we feel is very boring and doctors are not too much interested. But I must say, all the sessions were really very interesting, and all the chairperson guests have actually put in their effort to make the presentation and make the session very interactive, and we can see that with the number of people who have logged in and seen this. So I must just say, tell you all that we have got more than 120 people attending this session live at a time, and the praises which all the speakers have got speaks for themselves. So thank you very much for giving us the time, and I would just like to reiterate at the end that Bayer is an organization which stands for the women, and we have all these brands including Mirena, Vizan, Diane, Yasmin, Yaz, and Progainova, who are there to support women, and we are the world leader in women's health with innovation at the heart. And since we've been talking about contraception, so just towards the end, we are the global leaders in hormonal contraception as well, with the two brands which we have, Yasmin and Yes, launched in over 95 countries, and we have all the studies backing us, which tells that it is used by millions of women and we are imported and manufactured in Germany. So with that, I would like to thank you once again, everyone, and special thanks to AOGD for giving Bayer the opportunity to conduct this session. Thank you very much and have a nice evening.
Thank you, everybody. Hope we have not overshot time, quite a lot. 20 minutes we have overshot.
No, ma'am,
Thank
but it
you.
was interesting enough to stay away.
Thank you. Thank you so much. Bye-bye. Thank you.
Okay, bye.
Thank you. Thank you, everyone.